Welcome to MIGS Unplugged, live from Rome at WGC. I'm Arsham Sheybani here with Ahmed and of course Dr. Zeynep Aktas. Thank you for joining us today.
My pleasure.
So you do pediatric glaucoma, and I think there was a very traditional way to practice pediatrics, and I actually think with the advent of MIGS and angle surgery becoming more commonplace, that has changed a little bit. Can you tell us just basically what you've been doing, what has changed for you in the last 10 years?
Okay, actually nothing changed, but we just modified some techniques, okay? So it's a bit different in pediatric glaucoma because it's, so most of it developmental glaucoma, okay? So in developmental glaucomas like primary congenital glaucoma, the first treatment choice is generally surgery. Because there's a mainly anatomical problem, developmental problem in the angle. So we generally start with angle surgery. We can go for ab-externo, depending on the corneal status or our surgical preference for sure, or we can go for ab-interno technique. So ab-interno technique has been modified in recent years, and GATT surgery introduced into the surgical techniques. And it's actually my go-to procedure in these cases, because we know that if we go for circumferential surgery, the surgical outcomes is more favorable. So it's my starting point.
Yeah, and to be honest with you, I mean, you probably could argue those are the original mixed procedures in a sense, right? In that way. How has things evolved from the classical goniotomy to suture GATT, and now we have other options available because of the the new MIGS era. We have catheterization and viscodilation. Is there a role for this in pediatric glaucoma? Is there a role for stenting along with these devices? Do we have any experience, any thoughts on those adjuncts, either with canaloplasty or something else like that with GATT?
Yeah. Actually, we don't have that much evidence on stenting techniques, okay? We have a couple of case reports in the literature, including Zen, and no paper on iStents. And of course, adding dilation, viscodilation to the incisional procedures has a positive effect on the surgical outcomes. But I don't have any experience on eye tracts and these kind of viscodilating agents because it's not available in Turkey. But I have some sort of experience on GATT, mostly on GATT procedures. And we have another surgical instruments available in Turkey, which is Kahuk. Kahuk, another incisional option in these kind of kits. And also we can do bank procedure as you introduced. So these kind of incisional procedures has a role for the treatment, in the treatment of developmental glaucomas for sure. And now we have some preliminary data. So the studies are still going on microshunt. Maybe it might have some role in the future for the treatment of.
I was going to ask you that because I mean I think we all agree that angle procedures do fairly well in congenital, pediatric, and juvenile glaucoma. And whether you use a suture, catheter is nice in terms of having a lit tip and seeing where you are. Viscodilation may or may not have a benefit, but doesn't have this much downside. Stenting, I agree. But the subconjunctival procedures are where I think we have challenges in our kids. You've tried an angle procedure once or twice, hasn't been enough. Trabs, mitomycin trabs, we know the issues with that in kids. Tubes, have the limited efficacy. So I think I'm curious to see what you think about these, our new microinvasive bleb surgical options.
Bleb surgical options,
so like
I think
Zen
it's a problem.
for example.
It's a problem. We just don't know if it stays there, it can stay there for a lifetime. So I have some questions about the material of Zen. So we'll see what happens with microshunt. On the other hand, we have some other problems with the other surgeries. For example, using suture, it's kind of tricky in kids. If you have a catheter, you have the advantage of seeing where you are, okay? While introducing something into the Schlemm's canal, it's a problem. Yeah, you can do it with your, once you improve your surgical technique for sure. But what I do is, you used to have a 5-4 Prolin suture. This is my preference. So it's kind of less pliable in the Schlemm's canal. So in the kids' Schlemm's canal, sometimes it's hard to advance the suture because the Schlemm's canal might not be patent all the way around, and it might get into false passage easily. Another problem is this, the scleral elasticity of the kids. Okay, so it might get into again a false passage. So you need to check the suture's position because there's no light in the Schlemm's canal. I tend to introduce the suture in the Schlemm's canal and check its position very frequently. And when it comes to bleb-based surgical techniques, as you asked, I don't feel comfortable, while applying mitomycin on a ophthalmic eye. So I just don't prefer it. So I just also don't prefer to combine things. For example, it's very common in India. You can combine an advanced glaucoma, like a couple of procedures, you can do trabeculotomy, trabeculectomy. It's not my go-to procedure in these cases. I just start with trabeculotomy for these safety concerns, which I don't like.
We have some controversy and discussion about how much of the angle we need to treat for the first treatment. Is it 90, 120, 180, 360? We have some data on adults. What is your feeling on kids? Are you always doing 360 since you're in there once and you want to do everything you can?
Definitely. And my go-to procedure is, it can be ab interno or ab externo. I go for 360 first because studies show that if you do it 360 circumferential, you get more favorable results.
Excellent. Well, thanks, Zeynep. I think kids are some of our hardest patients to treat.
Thank you.
And they aren't just little people, of course. They have their own unique makeup and their own approach. And we do hope that companies and industry and our colleagues will continue to work to develop better ways to treat our pediatric population. Because often they get the hand-me-downs from the adult world, and I think they do require their own specialized approaches. So perhaps some of the learnings from MIGS will be applied to the pediatric population as well. But keep up the great work you're doing and serving the underserved as well, and are very difficult cases in the pediatric world. So thank you so much for that.
Thank you.
I didn't get the shoe memo though, guys.
Oh yeah,
so everyone's white.
We're going white sneakers here at home. But someone didn't get the memo.
I don't see.
There
You got to warn me next time.
We'll do that the next MIGS Unplugged. But thank you so much for joining us here for this episode from Rome at WGC. We've got a lot more things coming up. You're going to see some real unplugged, uncensored MIGS on streets of Rome coming up. Be aware. Watch it.